Program director or facilitator of the programs, my apology, I did not hear. I hope I'm audible. Colleagues from the Rural Doctors Associations of South Africa and also from the Rural Rehabilitation Professional Associations of the Clinical Associate, also most importantly, colleagues from the Rural Nursing of South Africa, distinguished guests, ladies and gentlemen, on behalf of our province, Limpopo, allow me, facilitator, to thank you for this generous invitation to this very important rural health conference. For us as a province, we feel and we're truly honored to be part of this important assembly of healthcare professionals and specialists from various disciplines. We know as a province that this meeting, we do have different or multidisciplinary teams that are responsible for patient care, whether it's your medical doctors, your dentists, your nurses, your physiotherapists, your clinical associates, students, and of course the NGOs that always support us as the health sector and work closely with us so that we can facilitate of healthcare services, especially to the most rural and the poorest of the poor, not forgetting our university community, whether it's lecturers who are part of this critical meeting. As a province, we want to commend your organization for the 25 years of unwavering commitment towards rural healthcare. You would remember that prior my joining politics on a full-time basis, I am not sure what is the problem. I used to be part of you. I remember we used to crisscross the provinces and visit the most deep rural areas for us to be able to make sure that we continue to be advocates of the rural people. We welcome you to our province with the knowledge that you are our most trusted allies in the collective struggle to ensure a long and healthy life for our people. Your important conference is taking place amidst an ongoing and ravaging coronavirus pandemic. The novel coronavirus has presented a healthcare challenge unprecedented in the magnitude since the discovery of the human immune virus over 50 years ago.
Where is your computer? Which is your computer on?
This is my computer.
Yes, which one on?
What the corona?
That one, you have to mute your computer.
It is.
Okay, mute that.
What the coronavirus pandemic has highlighted is the urgency of equity in the provision of healthcare services across the board. In our context, the demand for equity should mean a deliberate and focused attention to rural healthcare. This means a biased attention towards improving healthcare services and infrastructure in the most deepest of our rural villages. The clarion call for equity in healthcare provision should be targeted at destroying the ivory towers of privilege in accessing healthcare services. Access to healthcare cannot and should not remain an exclusive privilege for the privileged few. Access to primary healthcare in particular is a universal human right. It is a human right issue. Quality healthcare is not and should never be reduced to a commodity available only to those with deep elastic pockets that can stretch. It is against this background that we want to commend your work as the Rural Doctors Association, as the Rural Rehabilitation, as Professional Association of Clinical Associates, as Rural Nursing South Africa. For our part as government, we continue to try to match your commitment with our commitment of implementing the National Health Insurance. As you know that the NHI aims to achieve universal healthcare coverage for all South Africans. Indeed, the NHI aims to provide equity and social solidarity through pooling of risks and funds. This is the spirit of solidarity, which will see us closing the gap between the poor and the rich, between the urban and the rural. Through the implementation of NHI, we will close the gap between all these inequality that we continue to see, which are perpetuated by the geographic location of individual. Rural healthcare facilities and rural healthcare users will be the ultimate beneficiaries of this progressive healthcare insurance. We know that we can claim your full support when it comes to the implementation of this rural health insurance, of this national health insurance, which will see funds, inequality distribution of funds that we currently see happening, where the haves continue to benefit and the haves are being subsidized by the have-not. And we continue to indicate this in most cases, and people do not understand what we mean. To say an ordinary citizen who's also contribute towards VET will not have access to quality healthcare, but an MEC who is subsidized in terms of a medical insurance by the poorest of the poor, because state funds are supposed to be the funds for the poorest of the poor. But instead, they subsidize our medical insurance, and we continue to enjoy the access of private healthcare, while the poorest, whose funds are subsidizing us, continue to be subjected to the long queues with poor infrastructure, with shortage of staff, with all sorts of, very better the challenges that continue to face us. Over the past few years, I must indicate to you, as Limpopo Department of Health, we felt we are not going to wait for this national health insurance. But however, we started to say, let's invest heavily towards improving infrastructure within the rural area, towards making sure that even equipment and services at our rural healthcare facilities are improved. The face of our rural healthcare in the province, it's without a doubt changing for the better. I must confess that the challenges are still too many, but we are working towards making sure that the rural health, even in terms of our budget, that the allocation must be biased to the rural healthcare. Let me also give you an example that currently a significant number of our clinics have reached what we call the ideal clinic status. And most of them are in the rural areas. An ideal clinic which will have a good infrastructure, which will have adequate staff, which will have adequate medicines and supplies, good administrative processes, and sufficient bulk supplies. Of course, this is a clinic that is supposed to operate 24 hours. And at the challenge, we need to indicate that COVID-19 did not assist, because while we were still on the positive track to try to achieve all this, unfortunately, we were hit hard by the pandemic, which then dictated that 3 billion rands from our province has to be cut, and we were told we need to fund the very same COVID-19. And that also is a huge setback, because it's also having impact on this rural healthcare. If you remember, we had started to invest, even using the very same tertiary grants, those grants that are supposed to be directed only on tertiary services. We indicated as a province, just to share with you, that tertiary services cannot be left for Pietersburg and Mankweng Hospital only. Tertiary services can still benefit the rural area. That is why today Chiridzini, even if it doesn't have a full-time radiologist, but it does have a CT scan. And through technology, we've been able to make sure that all our 5 districts, because they are all in the rural areas, your hospitals like Chilidzini, Letaba, Mukopani, they do have those CT scans, even though they don't have the radiologist. But through the current technology that we are using, which we call a PEC-RIS, we are able to connect, and a patient from Hachikunda Marema or Hanjakajak does not have to travel 200 kilometers for CT scan in Pietersburg. This is something that used to happen in the past, but the patient can be done a scan in their own district. And through this system, a radiologist in Pietersburg Hospital will be able to read, interpret, and be able to send back the report to the doctor or the surgeon who will be in that side, and the diagnosis will be fast-tracked and the patient will be operated. We use the funds that are for tertiary services because that is a tertiary service which should be accessed not only by those who are in tertiary, but even those who are in the rural area. People should not be disadvantaged because of their geographic location. So we always, and we are currently using combining education, research, and training, and not limit it to Pietersburg and Mankweng. With our medical school, that it's yet to produce the first group, which is doing the final year. They are all rotating in terms of their blocks in those 5 districts in the regional hospital. They are also being exposed to rural health so that they're not only confined to Pietersburg and Mankweng. As I speak, there's a group that is in Letaba, so they will be rotating to all our regional hospitals where they'll also get a lot of knowledge. Last year, after we have experienced serious challenges imposed by COVID-19, not only unique to Limpopo, we realized that many patients who have got other chronic conditions, including patients who are supposed to be on ARVs, they get to be compromised during the waves of COVID-19. Patients with diabetes, patients who are supposed to collect their chronic medications in the clinic, because everybody is worried about COVID-19, forgetting that we are not the department of COVID-19, we are a department of health, and we must keep everybody being healthy by looking at dealing with all the diseases that are out there. If we look today, some of us are attacked. Just to me, give a real simple example that if somebody owns a pub, because they have got right of admission, which is reserved, that if you are wearing jeans and all-stars, you are not allowed access. Why don't we explore the same right of admissions which are reserved and indicate that if you are not vaccinated, you cannot, because you will endanger my staff and my other clients. There's been a big war outbreak in the country for just suggesting that, about us wanting to take away the right of somebody to buy alcohol, as if, as we speak now, on Saturday and Friday, you are buying alcohol, because alcohol currently, because of the wave, it's being sold from Monday to Thursday. So we want to appeal to the rural health professionals to support us on this call. Because if we look at when we push it to the economic cluster to say deny people alcohol, deny people the benefits of watching the games, deny people this and this, it's not because we want to infringe on their rights, but we are asking ourselves that the past 3 waves, have really caused serious havoc on the human rights of other patients. Let me give you a simple example. Currently, the backlog that we have in terms of surgical, it's really worrying. If you look at before the COVID-19, we would continue to try to find ways on how to clear surgical backlogs. But when you are in the middle of the wave, you cannot do that. When the president called the family meeting, not only does he talk about alcohol sales restriction, even in our own facility, you know, we are told you cannot perform elective procedures. What you must concentrate on is to fight COVID-19. So this is the question that I want to ask all those who are saying we are really infringing their rights, including the human rights in our province, who says they will fight government up until as long as government can want to introduce something like self-regulation, because we never spoke about mandatory, we spoke about self-regulation. My question would be, what are we saying about a woman from Achikudamalema with the breast cancer, and each time there is a wave, the poor woman is told, you're not gonna have access to your radiation oncology because everybody, all our beds are focusing on COVID-19. If you have someone with a fracture, you are told, we cannot deal with elective orthopedic cases. The only surgical procedures will be your emergency cesarean section, your ectopic, and all that. Forgetting that in the health system, that is why we have got a triage system where you have a P1 and up to P4. And if your priority 4 patient, it's not at priority 3 patient is not attended to, they will convert to priority 2. If they are not attended, they'll convert to priority 1. If not attended, to priority 4, which is death. So even in those cases, those surgical cases, we are seeing patients converting to priority 4 because they are still waiting for the wave to subsidize, or the wave for us to say, now we are fine as a country, we can open the hospital. And that, unfortunately, it's taking away lives of innocent, especially the rural poor. The question that I was asking was that, come the 4th wave, when the 4th wave comes, those who have, if majority of us are vaccinated, that means people are going to get sick and the country is going to be closed. That includes our hospital. Now that woman with the breast cancer who has vaccinated because she's afraid of COVID, she's going to suffer. She's going to die of COVID because, not of COVID, she's going to die because of her breast cancer. Whereas somebody who has refused to be vaccinated, we are going to be running around creating ICU beds, creating oxygen beds. Colleagues, we have nursed people during the 1st wave, we have nursed them for 2nd wave, we have nursed them during the 3rd wave. We are saying to them, don't ask us about our state of readiness in terms of ICU beds currently, in terms of ventilators currently. Ask us about our state of readiness in terms of 70% of our people getting to be vaccinated. And that's why you will understand why we are really so much, some of us, committed to fight until everybody gets vaccinated, because we have seen that that is the only solution for now, which is scientifically proven, that if we get people vaccinated, we will be able to avert the 4th wave. And that lady with the breast cancer will not be told that your cases will be postponed. As a province, as I move forward in support of rural health, last year, when we see that after the hard lockdown, we launched a project on the 15th of August, 2020, which is called Rural Health Matters. This is a project that I felt in my office. When people ask me to say, it's your birthday today, what do you want us to do for you? My question was to say, count my number of years and get women with cataracts and open and their eyes, operate those cataracts. And please don't do it in Mankweng or in Pietersburg. Do it in the deep rural hospital. That's why you saw people, our ophthalmologists, saying, indeed, we will go to the rural areas. That's where we are going to remove cataracts. Instead of removing those numbers that we had thought, we saw on that day more than 200 patients arriving in the hospital with long backlogs of cataracts, to say they've been waiting, some of them for 4 years, for 5 years. Hence, you saw that's when we gave birth to this project called Rural Health Matters. And with this Rural Health Matters, up to so far, we have seen so many patients in the rural areas benefiting. We have been able to take away specialists from different disciplines. Every month, they rotate across the district where they will go, whether it's plastic and reconstructive surgery. You will be surprised that Donald Fraser Hospital, it's the one that is operated, that woman who was called a witch because she had huge keloids and she could not walk, she was staying at home. She was operated in Donald Fraser. We would not have picked her up if it was not because of this campaign. We have seen women who were asked every day, when are you going to give birth? Because of this huge abdomen, not knowing that it's a uterine a tumor that has been growing for many years. And she was called a witch because she's failing to give birth. And that had a lot of impact on her self-esteem. We have seen her being operated in Malamulele Hospital. That's the deep rural area. We have seen patients at CN Patudi with all these mandible tumors that were huge and they were operated there. So what we are trying to show with our Rural Health Matters is that not everything must be done in the cities. Everything is possible to be done in the rural areas. They are using the very same theaters. They are using the very same theater nurses. They are using the very same medical officers to dope for them. What we bring, it's our specialist. And what we love about this project is that there is no medical officer in Limpopo who can claim today that they cannot perform an appendicectomy. That can indicate that they can't deal with undescended testes, because we have been exposing them to work with our pediatric surgeon, to work with our urologists. So we are saying to our urologists, gone are the days where you sit here in Pietersburg and Mankweng and wait for patients to come. You are going to leave this comfort zone and spend a week in those rural areas. And what I like about our team is that they don't mind. They leave their comfort homes in the Polokwane, which is our city in the standards of Limpopo, because we don't have a metro here. But they are able to go to those areas and spend the whole week. Our project has attracted even professors like Professor Machidze from Free State University. He's a son of the soil, but he takes his time off to go and operate all those orthopedic cases. We have seen Professor Bengo leaving Charlotte Maxeke to come to Limpopo and be able to teach our medical officers and our doctors how to do thyroidectomies in those rural areas. So for me, rural health will continue to matter because it is more important than even urban health. People in the urban area have got alternatives. People in the rural areas, they do not have alternatives. So our project, most of the time, it gets hit hard when the wave. Each time there's a wave, unfortunately, we can't overstretch ourselves. All of us must focus on COVID. So the rights of these people that are supposed to be operated are continuously really affected whenever we close. But don't make a mistake. There's no way that the president won't close the country. If people are sick with COVID, he has to find a way. And the only other way in the past 3 waves was to make sure that we lock down the country. But we're saying here, the very same president and his cabinet, they've given us vaccines which have proven to be efficient. We have seen healthcare workers. In my province, I can talk with pride. I've not lost any single healthcare worker who was vaccinated. I've lost healthcare workers who were not vaccinated. And that is a fact. So for me, the current vaccines that we have are able to reduce mortality rate. They are able to reduce severe illness. So why can't our people help and join hands with us and agree to be vaccinated? So we will continue to work with you in making sure that Limpopo also continue to focus on rural health. Hence, I've said, we feel honored you did not make a mistake for asking this province to host you, because this is the province that when it thinks about rural health, it always continue to say, even our budget must focus on the rural health. You might think that the budget is allocated in Pietersburg or Mankweng, but the fact of the matter is that when the implementation comes, we find a way on how to support our rural hospitals. And having done that, we have seen a lot of progress, and we have seen even our rural hospitals starting to improve in the services. But I must indicate that the journey is too long, and we need to also appreciate our honest partnership and collaboration with different stakeholders. We still reach out to our traditional healers. We still reach out to our traditional leaders. We still also reach out to faith-based organizations, because sometimes lack of information is the one that take our people outside, and they tend to make decisions because they are uninformed. Hence, you might have seen that even in our vaccination program, our message was very clear. We are a rural province, and we have, having noted that when the whole process was launched and we were told that it's gonna be done through EVDS, that was again that decision on its own, which is of course a beneficiary, because this is the first time as a country we've got one electronic system that is used by both public and private sector, owned by the state. So that's the first time. So we all as a province says, but if you are saying you want to vaccinate people when they are registered there, already you have discriminated. Already, where is the equity? You are telling a rural elderly woman who does not have a smartphone, who also does not have network connectivity in a village, who knows nothing about internet, how is she going to get to register and be vaccinated? As a province, because we know ourselves, we were ahead of everybody by bringing innovative ideas to mitigate for this particular hindrances towards making sure that the people who deserve vaccines get it. Hence, you saw us getting our community healthcare workers. These are our game changer. These are the people that we must continue to appreciate, using the strategies that we did, working with them in the fight of HIV and AIDS. We still use the very same system. Even during the household screening, we still use the very same cadres that were working with us during HIV and AIDS. We use them even now, even with the registration, they've registered. Even now when we are going for a mop-up of all those who need to be vaccinated, because for us, we are not that excited when you get 10,000 18-year-old vaccinated, when you don't have a 65-year-old being vaccinated. Ours has always been saying, if we can get 99% of the 60 and above vaccinated, and 95 and 80% of the above 50 vaccinated, and 70% of the above 35 being vaccinated, and then you can talk of the last 67% of the 18 to 34. For us, that will be, we would have achieved what we wanted, because in that you would have vaccinated those that really needs the vaccine when times comes. If you are hit by the wave, if those are vaccinated, you know that you are safe. So to reach out to those, because majority of them are in those rural areas, we had to use our community healthcare work because we know without them, we won't be able to achieve. So we want to really reassure the team here to say, in Limpopo, you've got a dependent early. In Limpopo, you just need to call and request a meeting. When you don't understand certain issues that you hear about Limpopo on the media, don't jump into conclusion. The MEC's office is always available. We will clarify you, and you will realize after clarifying you that what we were doing, our decision was mainly for the poor and the rural people. Ours has never been for the rich. That is why most of the time we'll be under attack. Because when I have to choose between a poor domestic worker and an average a doctor, I will choose a poor domestic worker, because a doctor can always have alternatives, but a domestic worker will never have an alternative. So that is why we're saying, as a province, we're calling upon all of you as the leadership of all those structures that have convened us to be here today, that join us, be with us. We work with people on the ground. We want to work with people who are there with the people. We can get together, and indeed the support and the respect that we continue to receive from our people on the ground, we think we can join forces with you and speak in loud voice as together for the sake of the health of our nation. And our partnership must never be a competition. We need each other. When we do the Rural Healthcare Matters project, you come on board as our partners. We can always go further. We are not here to compete. We are here to collaborate. Even all the NGOs, they know we are here to collaborate. Sometimes we will not agree on the approach. We sit down and talk about that, and they will then begin to appreciate that the department has taken this position mainly because of 1, 2, 3, 4. And the program director and facilitators, let me conclude by saying, I know that the main business for this conference is still too long ahead, and I would therefore not want to continue to hold you hostage with all my long and welcome remarks. But however, I really appreciate this moment which you gave me, because talking to you, it makes me feel, I don't know, honored, because I'm talking to people who understand the language that I speak. Whatever I'm going to say, it's what they themselves understand and they themselves appreciate. We share common understanding that rural health has been undermined for too long. But this is the time wherein rural health must be respected, and rural health must also be seen as forming a critical part. When the cake, when the budget is being cut, can we really spare the rural health? Because when you cut with the rural health, you are cutting for those that you have been cutting, you are left with a bone. Maybe when you cut in the urban, at least they still have meat to cut on. But on the rural health, we do not have any meat anymore to cut. You then cut their bones. Therefore, Program Director, let me wish you a fruitful and successful conference. Thank you very much. Ndoribuwa, nikensile sunene, inkomu, baya danki, sialocha matebele, asemgobani. So in simple language, I'm saying, me amukeriwili, ashfunzankulu sha Limpopo, botanganedziwa pano kavundula Limpopo, rile amugechi mo province ya rena, province ya Lerato, province ya urata batho ya Limpopo, mushati.